Good morning, everybody. Thank you for joining the session on CDH and ECMO. My name is Megan Arnold. I'm an associate professor of surgery and surgical director of the Children's Intestinal Rehab Program at the University of Michigan. You may ask why someone who does intestinal failure is moderating a CDH ECMO session. I also am board certified in critical care. Joining me is co-moderator Dr. Tim Janselowitz. He is Associate Professor of Surgery and Pediatrics, as well as Interim Division Chief at Le Bonheur Children's Hospital in Memphis. We're going to start off this morning with our first abstract titled Impact of a Congenital Heart Disease Diagnosis on Congenital Diaphragmatic Hernia Outcomes, to be presented by Dr. Kylie Holden.
Thank you so much. Thank you to the APSA Scientific Committee, Dr. Arnold and Dr. Janselowitz, for the opportunity to present our work. We have no conflicts or disclosures. As we all know, infants with CDH have defects in their diaphragm that allow the herniation of the abdominal contents into the hemithorax, causing compression of the cardiopulmonary system, resulting most notably in pulmonary hypertension. The best predictors for their morbidity and mortality is the CDH-SG stage or diaphragm defect size scoring system. This allows us to risk stratify infants with larger defects representing higher risks. CDH is often associated with other comorbidities, most commonly with congenital cardiac anomalies. Congenital cardiac anomalies are associated in 20% of our CDH population. There are a broad range of malformations that have a significant impact on the layer of complication of management, specifically with their surgical management. This is likely because of how the pulmonary hypertension in CDH interplays with the cardiac physiology. It is the balance of these two things that impact the surgical decision-making process. We completed this research to address the current gaps in knowledge related to the optimal management, surgical decision-making, and outcomes of these infants, and find it's important to evaluate these outcomes in a large multi-institutional study to bridge this gap. For our objectives, we wanted to determine the incidence and clinical characteristics of these infants, provide insight into surgical decision-making, and assess survival. This is a retrospective analysis from the CDH Study Group Registry from 2007 to 2022. We queried all patients with CDH and CHD, or congenital heart defects. We looked at their diaphragm defect size, their cardiac diagnosis, looked at their critical care management, and operative details. We performed non-parametric and multivariable analysis. We found 9,000 patients total in this time period, with 7,000 of them having isolated CDH. 400 had CDH plus a chromosomal anomaly, and 1,886, or about 20% of the population, were found to have CDH plus a CHD. Within that, 60% had a minor cardiac anomaly, 25% had a major cardiac anomaly, 11% had an isolated aortic arch, and 3% had an other less commonly diagnosed anomaly. We're going to focus specifically on those with major and minor anomalies. Now, in comparing these two populations, there are many similarities, but there are a few important comparisons to note. Chromosomal anomalies, for example, 15% of the minor anomaly patients had a chromosomal anomaly, while 22% in the major group had a chromosomal anomaly. The use of ECLS also varied. 30% of the minor anomalies utilized ECLS, while only 20% in the majors did. When looking at the diaphragm defect distribution size, they're very similar in the two groups. This is important to note as it likely does not impact the survival differences we see. So the first step is looking at their diaphragm, who undergoes diaphragm repair. Within the minor category, we see 85% of the population undergoes diaphragm repair, while in the major group, only 57% do. This impacts survival. As we know, the unrepaired diaphragm survival is about 0%, but when the diaphragm is repaired, survival increases to 80%. With the minor patients that undergo diaphragm repair, survival increases to 82%, and survival for the major patients is 70%. The next step is looking at who undergoes cardiac repair. Only 7% of the patients with minor anomalies undergo cardiac repair in the same hospitalization, and that 22% in the major group do. We look at the survival for the minor patients that do not undergo cardiac repair, and that's about 70%. When their cardiac repair is done, it increases to about 78%. For major patients that have no cardiac repair, their survival is 32%. When their defect is repaired, that increases to 77%. In a multivariable analysis, looking at the factors that are associated with diaphragm and cardiac repair, for diaphragm repair, higher APGAR scores and a lack of a chromosomal anomaly were all found to be associated with the decision to have diaphragm repair. In the cardiac repair, days intubated, undergoing diaphragm repair, specific cardiac diagnosis, and the lack of a chromosomal anomaly were all associated with this decision as well. Now, with this data set, we're able then to analyze mortality and stratify that by diaphragm defect size and cardiac surgical risk. Cardiac surgical risk can be stratified by stat category, where higher values represent a higher risk of mortality. As you can see, the lowest mortality is associated with smaller defects, A's and B's, and the highest mortality is associated with larger C and D defects and higher stat categories. It's very important to note, however, that in this particular study, we only looked at those that underwent diaphragm and cardiac repair, and that those with D defects did not undergo a Stat 5 operation. So in conclusion, we can see that diaphragm and cardiac repair are essential for survival. Following diaphragm repair, consideration for cardiac repair can now be personalized based on specific cardiac diagnosis. And successful outcomes for cardiac operations following diaphragm repair are influenced by both diaphragm defect size and severity, as well as stat category risk. The next steps for this project are to look at and understanding the surgical timing of the cardiac repair. Thank you.
This abstract is now open for questions.
Kunisaki, Hopkins, phenomenal study. I think really important. I look forward to the contribution of this in the literature. I think from a prenatal counseling perspective, I think a lot of information will be gained from this. I have two questions. The first is, this is obviously a pretty long time period, 25 plus years. Did you look at survival and these changes over time? Are we getting better at managing these kids, or is that something that's a work in progress? That's my first question. The second question is, I know the CDH study group has prenatal variables now that have been added. And can you comment a little bit about sort of this interplay between lung volume size and some of these outcome measures? Thank you.
For your first question, for approval over time, yes, we have gotten better. And so for our multivariable analysis, we were able to control for that, to kind of take that out of the equation to see, it does cluster the data and it does affect the way that we manage patients. And so for this multivariable analysis, we were able to take that out. I think it'd be an interesting layer to add in the paper to see how that interplays. And for your second question, for this study, we did not look at the prenatal diagnoses. However, we know that the diaphragm defect size correlates with prenatal diagnoses. And so we're able, or ODE, LHR, stuff like that. So we're able to, I guess, extrapolate evidence based on this. Again, another further step would be great to look at the prenatal diagnosis.
Thank you very much.
The next presentation is Impact of a Center's Total Neonatal Extracorporeal Life Support Volume on Mortality and its Relationship with CDH. Be presented by Dr. Yeet Gunnar from Orange County.
Thank you. Thank you. I have no disclosures. For the last 3 to 4 years, we've been looking at center as an explanation for variation in adverse outcomes, the most important, which is mortality. Specific to ECMO and CDH, we published a study in 2022, and what we found out was there were some centers that had more favorable outcomes compared to other centers with less favorable outcomes. Now, sometimes variation can be explained by some things, one of which is volume. So we did a follow-up study, and we found out that centers that had low volume, which we defined as having at least 2 ECLS cases annually, had the higher mortality compared to medium and high volume centers. Now, with that in the background, we did this current study in a more holistic approach to say, what is your total neonatal ECMO volume, and how does that impact, say, your CDH survival and your total neonatal ECMO survival? Because the teams we use are the same teams. It's the same primers, it's the same content experts. And the more you do, perhaps it all ties in. There are 3 separate questions, combinations of questions. And when I mean total volume, I mean your total only neonatal ECMO volume. How does that impact your total neonatal ECMO survival? But specific to this study, how does that impact your CDH survival on ECMO? And how about your non-ECMO volume put together? Does that impact your CDH survival? This was also study, two populations, CDH and non-CDH. Mortality is our outcome, and exposure is volume. So low, medium, high, defined by tertiles of volume variable in a non-biased way. With that, we had about a little over 30,000 patients for 23 years of data, 295 centers before exclusions, which then reduced to 237 centers with about 29,500-ish cases and about 6,700 and some change CDH and 22,700 non-CDH cases. So let's kind of look at how these kind of broke down. This is just some observational findings of the study. So total neonatal ECMO mortality is about 40% for the last 23 years added up. CDH, as we know, is about 50%. Congenital diaphragmatic hernia is right there with it. And then meconium aspiration is about 7%. The rest are listed. So this kind of distribution of the incidence of the different primary indications for ECMO. So the big orange line is CDH. You can see it's kind of been going up over time. And then congenital heart disease is the other orange line above it. And then this other thing that's going up is everything that's other that I couldn't come up with a way to classify them. And meconium aspiration, PPHN have been on the downside. Okay, so how did we define low volume? As I said earlier, just basic tertiles of the volume variable. So centers that did about, there are no half patients, but let's say 28 cases, over 23 years would be low volume for their total neonatal ECMO cases and 22 cases for non-CDH. So the rest are listed on this table. So some unadjusted mortality observations. So we look at low volume, medium volume, high volume, and then separate them by CDH, non-CDH, and total volume. You can see sort of this decreasing incidence of unadjusted mortality. So those centers that do less have higher unadjusted mortality. But we always have to, compare apples to apples and risk adjust. So we did a regression model, busy table. But what we see here, the top, so this is the total experience of all your neonates getting ECMO, low volume centers. Odds ratio is 1.48 for mortality, significantly associated with mortality. And same thing for total volume, only within the CDH cohort. So your total neonatal volume affecting your CDH survival is also significant for low and medium centers compared to high. And your non-CDH volume in the bottom here also impacts your CDH survival, similar way. So number needed to treat. I'm not quite sure if this is quite applicable, but we thought it would be a good way to think about. So if you're a low volume center, beyond it, say 22 to 27, how many would you have to do to save one baby's life? So it's about 9 to 10 patients. Depends on the cohort that's described. And then one other thing I looked at, and this is only for the total neonatal experiences, occasionally there are complications that lead to us stopping the ECMO, entire ECMO plan. And that also is it's correlated with your volume. So low volume centers are more likely to stop their ECMO due to a complication. So in conclusion, sorry, not progressing. I've been thinking about what to say on this slide for a while, and honestly, I don't have a good way to explain this in my mind, because there's things I want to say that I prefer not to say, because I don't know, because there are feelings on the other side of these, there are teams and people, and but then I kind of realized we're kind of starting an improvement journey, and the first step in that journey was describing variation to all of us. The variation exists, and we've actually shown this from several other registries, because often our studies are criticized saying, well, it's not adequately risk adjusted. So those are also coming. But perhaps the place we need to be is sort of come together and come up with sort of metrics and design these improvement experiments and see where we get. Thank you.
Questions?
Similar question to the last paper, similar cohort size and sort of span of time, did you look at any smaller chunks of time? Were small volume centers always small, or did you do any sort of subgroup analysis to try and sort of hone in maybe on some more differences over shorter periods of time?
Yeah, if you look at a few centers and how they change their volume, then you kind of lose power. But I did do let's look at the last 5 years, let's look at the last 10 years, and the information is preserved. Like it's always true.
Thank you very much.
Thank you.
Thanks, you.
The next abstract is Clinical Care Trajectory Assessment of Children with Congenital Diaphragmatic Hernia and Neurodevelopmental Impairment, to be presented by Dr. Alexandria Dimmer.
Hello, and thank you so much for the opportunity to present our work. We conducted this research because the voices and perspectives of patients are rarely heard along their illness journey. And we are presenting this research today because we believe that it is an untapped and important avenue for quality improvement. We have no conflicts of interest to disclose. Patients with CDH often suffer from multisystem morbidity that affects both the child and their family. Structured long-term health surveillance is critical for the early identification and mitigation of this morbidity, especially for patients with neurodevelopmental impairment, or NDI. CDH infants at risk for NDI include those requiring oxygen supplementation at day of life 28, ECLS survivors, those requiring a patch repair, and those born prematurely. To date, very few studies have evaluated the impact of survivor morbidity on both the patient and their family. And what's even more concerning is the poor documentation of the efficacy of long-term health surveillance programs in mitigating this morbidity and supporting families. In addition, little is known about family satisfaction with these programs and other existing support resources. This study aims to bridge this gap. This study sought to address the following objectives: to describe the clinical care trajectory of patients with CDH and NDI, and to explore the lived experiences of families and their satisfaction with existing support resources. We hypothesized that CDH children with severe NDI and their families would have higher unmet needs and inferior lived experiences compared to CDH children without NDI over the trajectory of their illness. This mixed method study was conducted in 3 phases. Phase 1 involved an evaluation of clinical variables and assessment of clinic usage for patients both with and without NDI. Phase 2 is a survey assessment of satisfaction with known transition points in care and existing hospital resources. And lastly, Phase 3 involved a community consultation group interview with CDH families to explore themes related to the lived experience of CDH and to assist in the co-design of a moderator guide to be used in subsequent focus groups. With the exception of 5-minute APGAR and presence of GERD on discharge, the groups did not differ when comparing their demographics, their birth details, or condition on discharge. Here we can see that the severe NDI cohort required increased cardiorespiratory support and length of stay compared to the mild-moderate NDI and non-NDI cohorts. Additionally, the severe NDI cohort was more likely to require a patch surgical repair when compared with the other groups. This chart demonstrates the median number of scheduled and unscheduled visits per patient between the groups. The severe NDI cohort required many more unscheduled visits, represented by the hashed bars, when compared with the other groups, particularly in the first 4 years of life, where visits were the greatest amongst all groups. This chart demonstrates the breakdown of unscheduled visits in the first 4 years of life, and as you can see, the severe NDI cohort, represented by the solid gray bar, required many more emergency department, medical specialist, and ancillary visits than the other groups. Overall, parents were extremely satisfied with the care provided to their children. Despite this, areas for improvement emerged, including communication regarding differences in care routines between the NICU and ward, communication during NICU to ward transfer, communication between medical teams surrounding the CDH care plan, and lastly, increased opportunities for communication with other parents of CDH children. Thematic analysis of the community consultation yielded 3 main themes. The first was parental burden and uncertainties. Despite relief that their child had survived the neonatal period, many parents expressed uncertainty if knowing if certain traits in their children could be attributable to their CDH. In addition, parents also felt a strong desire to protect their children, which often led to parental anxiety. The second theme identified was lack of emotional support. Lack of emotional support was common, and this often led to frustration and isolation, resulting in all families expressing a desire to connect with other families. Lastly, the final theme was preoccupation of several families with the future. These families had difficulty finding information related to the quality of life and what their child's future would look like beyond their surgical repair. Our findings provide evidence that CDH patients with severe NDI require increased support in the first years of life. Specifically, these patients require many more visits than those recommended by the AAP guidelines. This finding highlights the importance of a truly multidisciplinary CDH clinic to reduce these unscheduled visits and lessen the burden on the emergency department. Our study also indicates that in general, parents are satisfied with the resources provided within our institution and the one-stop shop nature of our CDH clinic. However, areas for improvement remain, including improved communication amongst medical teams, particularly during NICU to ward transfer, and a strong desire of parents to interact with other CDH families. The results of this study will be used to drive discussion in future focus groups with CDH patients and their primary caregivers. In addition, opportunities for local quality improvement initiatives have emerged, including screening our patients for risk of NDI to offer increased health surveillance appointments to those patients with a high risk, multidisciplinary standardization efforts of the NICU to ward transfer process to ensure improved communication, and lastly, plans for the development of a local CDH family support network, a program which is strongly desired by many of our patients. I'd like to take a moment to acknowledge our sources of funding and to thank our entire team. I'll take any questions. Thank you.
Thank you for your presentation, Paul Ostley, Liverpool, England, Bangkok, Thailand. Were you able to interrogate the reasons for those hospital visits? Because with a multidisciplinary team and a care coordinator, you may be able to offset those distressing visits for families. And I'd have to put in a plug here for CDH UK. I am a patron. They're very good at dealing with these issues that can offset these hospital visits. So thank you for your talk.
Yeah, certainly that's a great question. Many of the visits were relating to feeding difficulties and weight checks and things like that. In addition, patients had additional needs, obviously requiring them to need PT, OT, audiology, those types of resources, which although they are able to receive those within our CDH clinic, it explains why the group with severe NDI would require increased visits of that nature. We do have a CDH care coordinator who I do believe is able to offset many of those visits, but it just goes to show us that this group is requiring more than we are currently giving them, and begs the question what more we can do for them moving forward. Thank you.
Matt Harding, Houston. Dr. Dimmer, you and Dr. Pulangandla are to be congratulated for addressing what I think is the single most important question that parents want to know. Right? Survival is great, and we do a lot of things to figure out are you going to survive or not. But if you survive, what does that look like for the family? And we can't answer that question right now, and it's studies like this that help to get there. So congratulations on that. My question is, how can we better understand earlier? Because, right, we don't really start to understand where kids are until they're 2 or 3 or 4. And it's really difficult to conduct studies. Reaching out to the families like you've done and doing some of these things are amazing. But how can we start to counsel patients before they're born? What do we need to do to have these data earlier? I think this is an important first step. What else do we need to do to know this earlier? Thank you.
That's a great question. I think we feel like doing this type of work at this time to gain more information about what the life course actually looks like over time will allow us to be able to better counsel our patients prenatally. I think especially within our institution, having a family support network within a local context is also critical because although support networks are available, if they cannot speak to the local context and local available resources, I think that's really a missing step that parents are really craving. And something that has come up within our community consultation and some of the focus groups that we've already started to conduct is really that families want to know what a child's life looks like at various time points across their trajectory. And obviously, we may not be able to predict it for each individual child, but to be able to have them speak with others or have a collection of experiences that show different snapshots of possibilities, I think is very helpful to families and assists us in our prenatal counseling efforts. Thank you.
Thank you. Next presentation is long-term outcomes following on ECMO muscle flap prepare for CDH, presented by Dr. Alyssa Vaughn from Children's Hospital, Colorado.
Thank you to APSA for the opportunity to present our research. Our team has no relevant disclosures. I did this research because I'm interested in optimizing the management of severe CDH. A lot of my previous research has focused on evaluating short-term outcomes following the muscle flap repair technique, and I was interested in investigating our longer-term outcomes. Various operative strategies are employed to address the largest CDH defects, with the muscle flap technique having gained interest over the past 2 decades. In contrast to a PTFE patch repair, an abdominal wall muscle flap utilizes autologous muscular vascularized tissue to repair the diaphragm in a tension-free manner. Benefits of this approach include its ability to grow with the patient, avoidance of a foreign body type reaction, and potential hemostatic advantage, given the use of native tissue. We have previously shown that the muscle flap technique is associated with decreased short-term bleeding complications in patients who underwent repair while on ECMO. However, flap repair does require the use of abdominal wall musculature. Therefore, one concern with this technique is the potential for long-term musculoskeletal complications due to the altered mechanics of the abdominal wall. Historically, prosthetic patches were used for the largest CDHs, unamenable to primary closure. Multiple studies have also shown that patients with the largest CDH defects have an increased incidence of musculoskeletal and chest wall deformities, including scoliosis rates ranging from 4 to 50%, reported rates of pectus ranging anywhere from 14 to 80%. Recurrence rates after patch repair have also been reported to range from 10 to 60%. In contrast, patients who undergo flap repair are hypothesized to have lower recurrence rates, ranging from 4 to 12% in the literature. We therefore sought to evaluate our long-term outcomes, including rates of recurrence and musculoskeletal complications following on ECMO CDH muscle flap repair. We chose to specifically evaluate this subpopulation, which underwent repair while on ECMO, to decrease the heterogeneity of the patient population, as well as to evaluate long-term outcomes in patients with the most severe disease, using on-ECMO repair as an additional marker of severity. To evaluate this, we retrospectively reviewed all patients who underwent on-ECMO CDH repair using a transversus abdominis muscle flap at our institution from 2015 to 2022. To evaluate long-term outcomes, we included only surviving patients at the time of our analysis who had reached at least 2 years of age. We evaluated long-term outcomes, including pectus deformities, scoliosis, ventral or incisional hernias, as well as recurrence rates. For reference to our institutional practices, the muscle flap technique, represented by the blue bars, was largely adopted in 2015, with the majority of on-ECMO CDH repairs since that time having used the muscle flap. A total of 34 patients underwent CDH repair on ECMO using the flap technique during our study period, with 19 of these being long-term survivors who met inclusion criteria. Length of follow-up was defined as the length of time from CDH repair to the most recent charted follow-up, with an average of 5 years. Basic demographics of our cohort included median gestational age at delivery of 38 weeks, average birth weight of 2,700 grams, 15 days on ECMO, PPLV of 16.7, and ODE-LHR of 35. 78% had a left-sided defect, and 63% had concomitant congenital heart disease. Notably, there were no CDH recurrences within our patient population, all of whom were at least 2 years of age at the time of analysis, with an average follow-up of 5 years. This is particularly important to note, given that approximately 75% of CDH recurrences occur within 2 years of age, and nearly 100% by age 5. Regarding musculoskeletal deformity rates, we found that 8 of our 19 patients had been diagnosed with at least one. These included 7 pectus deformities, of which 6 were mild and 1 moderate, 4 with scoliosis, all of which were mild, and none of these deformities have required intervention to date. However, given the still young age of these patients overall, this will be important to continue to evaluate prospectively. 2 patients were noted to have abdominal wall complications, of which one was an incisional hernia requiring operative repair, and 1 patient in whom the left abdominal wall was noted to bulge out. In conclusion, these results suggest that the muscle flap technique for on-ECMO CDH repair is safe, with similar rates of long-term musculoskeletal complications and decreased rates of recurrence, even on ECMO, compared to historical prosthetic patch repair complications. Our results further support the use of the muscle flap technique for on-ECMO CDH repair. I'd like to thank the following individuals, departments, and institutions for making this research possible. I can now take any questions.
Sharif Emile Montrealis, a very impressive series. Congratulations, really beautifully presented. I'd just like to know your perspective about the outcome you're studying, because it's my impression that MSK abnormalities are really a function of the diaphragmatic hernia, the asymmetry in the diaphragm, and the asymmetry of the lungs, the hypoplasia of the lungs. And the reason I'm saying that is we see a lot of patients in our long-term chest wall clinic who have had primary repairs, no patch, no muscle, and still end up with pectus and still end up with. So I'm just curious why you think that that's a reasonable outcome to look at, because I think that the hernia itself is really the main impetus for the musculoskeletal deformity, not so much how you repair it.
Yeah, excellent point. Thank you for bringing that up. I agree. There's certainly data to support that patients who undergo primary repair do have lower rates of these long-term musculoskeletal complications than patch or flap. Not zero, certainly. I think in those cases, the primary repair is a surrogate marker for a smaller defect. So, larger defects are more associated with these complications. I think from our standpoint in looking at this outcome was specifically to address the concern that the abdominal wall muscle flap alters the mechanics of the abdominal wall as they grow, such that that may contribute more and have an even higher rate of these musculoskeletal deformities compared to patch repair and certainly primary repair, but we know that that would be the case.
Did you have a sense of whether the defects were the musculoskeletal deformities were more common in the larger defects? Did you stratify by defect size?
Excellent point. Thank you. It's certainly a wonderful idea. I think it's hard with our particular operative notes in looking these retrospectively. They discuss kind of, an absent posterior rim or a very, very small amount of posterior rim of diaphragm, but it was not standardized to actually put, any kind of measurements or the type C, type D into the operative note. And so I imagine there's a correlation there in our data set, but was a little bit difficult to actually specifically stratify.
Okay. That's a reminder for everybody to record defect size in their operative reports, please. Thanks.
Thank you.
Our next presentation is a porcine model to evaluate cerebrovascular autoregulation during pumpless arteriovenous ECMO and veno-arterial ECMO support, to be presented by Dr. Alicia Eubanks.
Thank you for the privilege of the podium. We have no disclosures. ECMO is a life-saving intervention for patients with severe cardiorespiratory failure. Despite its survival benefit, conventional pump-driven veno-arterial ECMO bears the risk of serious neurologic complications for infants. Sequelae such as stroke, hemorrhage, and adverse long-term neurodevelopmental outcomes have been attributed in part to impaired cerebrovascular autoregulation in the setting of pump-driven non-pulsatile perfusion and the need for systemic anticoagulation. These ECMO factors serve as areas of opportunity for improvement in patient outcomes. Cerebral autoregulation refers to the physiologic mechanism that holds cerebral blood flow relatively constant across changes in systemic blood pressure. Impairment of autoregulation leaves the brain exquisitely vulnerable to hemorrhage or ischemia in the setting of hypertension or hypotension. This risk is even greater in preterm and young neonates with an immature germinal matrix. Studies in animals and humans have demonstrated an association between the loss of pulsatile flow to the brain and altered cerebrovascular autoregulation. One hypothesis as to the mechanism of alterations in autoregulation is that the flow and shear changes in VA ECMO may disrupt endothelial reactivity via alterations in the nitric oxide pathway. Traditional VA ECMO is pump-driven, which decreases the pulsatility of blood flow to the brain and the body. The length and prothrombotic surfaces of the circuit also necessitate the use of therapeutic anticoagulation, which increases the risk of intracranial hemorrhage. Our lab has developed a novel form of pumpless arteriovenous ECMO in which flow through the circuit is driven by native cardiac output, maintaining pulsatile flow to the brain. The objective of this study was to determine the relative impact of VA ECMO and pumpless ECMO on cerebral autoregulation of oxygen delivery and perfusion after cannulation and in response to physiologic stress. We hypothesized that animals on pumpless ECMO would maintain more physiologic cerebral perfusion and autoregulation, while animals on conventional VA ECMO would demonstrate dampened autoregulatory responses. 19 pediatric piglets were studied, 10 in the pumpless group and 9 in the conventional VA ECMO group. Animals were anesthetized, and then a non-invasive cranial optical spectroscopy probe measured local cerebral blood flow and tissue oxygenation. Invasive neuromonitors, including an ICP probe, microdialysis probe, and periflex laser Doppler, were placed through burr holes. Each piglet was then cannulated to pumpless or conventional ECMO with a cervical cannulation and an additional femoral venous cannula. Piglets in Study 1 were supported on ECMO for 6 hours with continuous monitoring of vital signs, ABGs, and spectroscopy. Piglets in Study 2 were allowed 30 minutes of stabilization on ECMO. Then ICP was progressively increased by infusion of an artificial CSF directly into the ventricles. ICP was increased to 50 millimeters of mercury above baseline in increments of 10 millimeters of mercury, with 30 minutes of monitoring at each ICP level. We utilized several invasive and non-invasive neuromonitors to collect data on cerebral perfusion, tissue oxygenation, and markers of anaerobic metabolism. This figure shows a pressure reactivity curve, PRX, over the 6-hour period of ECMO support. PRX is a measure of cerebral autoregulation assessing correlation between mean arterial pressure and ICP. Values at or below 0 represent preservation of autoregulation. PRX was significantly lower in the pumpless group, indicating superior preservation of cerebrovascular autoregulation in this cohort. MAP, ICP, and cerebral blood flow were not significantly different between study groups during steady-state flow. As we progressively increased ICP, we observed that the pumpless ECMO animals demonstrated a compensatory increase in mean arterial pressure. We've shown a correlation between ICP and MAP in the pumpless animals that we hypothesize represents preservation of cerebral perfusion as ICP increases, and this was absent in the conventional ECMO group. Here are ICP tracings on the top and MAP tracings on the bottom from 2 representative animals to show this relationship over time. You'll note that in the pumpless animal, the ICP tracing more closely mirrors the MAP tracing. Prior to cannulation, cerebral perfusion pressure was equivalent in both groups. Once on ECMO, however, we observed significantly lower CPP in the pumpless animals at lower and physiologic ICPs, and as ICP levels became critically high, this difference shrinks. Though we need to investigate this finding in further detail, this may represent a period of longer preservation of CPP in the setting of brain injury. We also found that the pressure reactivity index was lower in the pumpless ECMO group at higher levels of ICP, indicating better preservation of cerebrovascular autoregulation during physiologic stress. Perhaps one of our most interesting findings came from our microdialysis data. We measured tissue metabolic byproducts directly from the cerebral parenchyma, both over time in Study 1 and at each ICP level in Study 2. The lactate to pyruvate ratio reflects cytoplasmic redox state and thus provides information about tissue oxygenation. An elevated lactate to pyruvate ratio greater than 40 frequently is interpreted as a sign of cerebral hypoxemia or ischemia. In our animals, we observed a significantly higher lactate to pyruvate ratio in the VA ECMO animals over the course of 6 hours of stable ECMO support, indicating accumulating metabolic injury with time on ECMO. This effect was also observed in the ICP study, as the L/P ratio was significantly higher in the VA ECMO as ICP was increased. In conclusion, animals in the pumpless ECMO group had better preservation of cerebral autoregulation, both over a period of stable ECMO support and in response to increased intracranial pressure. Animals in both groups showed alterations in cerebral blood flow at critical levels of intracranial pressure, but the window of appropriate autoregulatory responses was better preserved in the pumpless ECMO group at physiologic levels and in response to mild injury. ECMO support alone caused metabolic stress in the brain parenchyma in the VA ECMO group, and this effect was further demonstrated in the injury model. We hypothesize that these results are in part due to the physiologic pulsatile flow that is preserved in the pumpless ECMO system. In clinical implementation, use of the pumpless ECMO system for appropriate candidates may ultimately decrease the neurologic risks of ECMO therapy for neonates. I'd like to extend our thanks to our amazing collaborators, as well as the University of Pennsylvania ITMAT for funding for this project. Thank you, and I'll take any questions.
That looks like a lot of work.
It sure was.
Congratulations.
Thank you.
My question is the clinical applicability of this pumpless system. Because I guess these are intact animal model. But what about in the setting of sepsis or CDH where the heart is hypoplastic? Can a pumpless support system be effective for ECMO exchange?
Thank you for your question. Our initial studies using the pumpless system have been in the CDH lamb model, and we found that in that model, the pumpless system provides appropriate stable support comparable to a VIII ECMO system. To your question of sepsis or decreased left ventricular output, that is an area where this system may not be as appropriate. This is really a surrogate for VV ECMO and best serves patients with isolated respiratory failure rather than cardiorespiratory failure. However, the cannulation strategy is the same as VIII ECMO, so an infant could theoretically be cannulated onto pumpless ECMO, and if they then develop heart failure, the circuit could just be exchanged to a VIII ECMO circuit.
Thank you.
Thank you.
Our next presentation is mediastinal shift index, validation of a postnatal measurement of mediastinal movement that predicts survival in neonates with CDH on ECMO. To be presented by Dr. Nicole Simbach from Boston.
Good afternoon, everyone. Thank you for the opportunity to present our work. We have no disclosures. As has been noted by this session, CDH continues to be a significant source of mortality in these patients. These two X-ray images are from two of our patients with a left CDH within their first few hours of life. This set of images was taken later on in their clinical course. We've all seen these images, and this top patient died, and unfortunately, this bottom patient survived. And what we sought to look at was, did the position of the mediastinum in these patients somehow affect their outcome? We know that the position of the mediastinum is important. The defect size, A through D, is often associated with significant changes in the lung volume. What's thought is that the size of the defect affects the amount that the mediastinum is pushed onto the good lung that's contralateral to the defect. And possibly remodeling the access to shift off of this good lung can encourage lung growth and therefore impact outcomes. Others have sought to look at the position of the mediastinum using specific measurements. These measurements were largely completed prenatally and require either radiological technology such as MRI prenatal measurements completed by a radiology team. Our study therefore had three objectives. We wanted to create a novel postnatal measurement to estimate mediastinal position. We wanted to validate this measurement, and then we wanted to understand how this measurement affects clinical outcomes. To do this, we looked at chest x-rays for each patient, and we used chest x-rays because they're routinely completed in our patients. We then looked at radio-opaque objects on imaging. The first one we looked at was enteral tubes, but because of the position of the esophagus and the variability in CDH patients, we didn't feel this would be as accurate. So we shifted our focus to central lines, and most notably ECMO cannula. Finally, we completed quality checks for chest x-rays on all of these patients. Sorry, I'm not sure why these are out of order. There you go. So now I'm going to describe how we actually completed this measurement. So the first thing we did was we selected images for each patient, and then we completed a measurement between the cannula and the chest wall contralateral to the defect. We did the same measurement, but from the vertebra to the chest wall contralateral to the defect, and we took the ratio of this. And this is what we call the mediastinal shift index. And what's important to note here is that the distance between the cannula and chest wall is what we were calling more severe. So that means a lower number is associated with more compression of that good lung and lower volumes. We had 105 patients screened. 40 of these were cannulated to ECMO, and our final population was 38. Within this population, about 70% survived to discharge, 90% were type C and D, which correlates with the fact that they were all on ECMO. 78% were repaired within 48 hours, and there were no significant demographic differences between the two cohorts. And so we completed this measurement at 3 main time points. The first was the day of ECMO cannulation. The second was within 48 hours of CDH repair. And the third was on the day of decannulation. So this is the same patient that I showed earlier in the study. And what you can see is that the MSI is very small. It's 0.32, indicating significant compression of that lung that's contralateral to the defect. And the MSI increases over time as the mediastinum moves. We wanted to validate our measurements between the 3 raters, and this shows high correlation coefficients, which indicate that the measurement is very reproducible. We then wanted to see if our initial ratios correlated with a known prenatal marker, in this case, O to E lung head ratio. And what we found was that there was moderate correlation, showing that MSI is not only reproducible, but correlates with a prenatal marker of severity. We then wanted to look at survival in these patients for MSI. And so what we saw is in patients who didn't survive, they actually had a lower MSI, again, indicating that more of that lung was compressed. This was the same for the prenatal marker. Since we were able to show that there was a difference in MSI between survivors and non-survivors, we wanted to push a little further and say, can we actually use this to predict which patients will survive? And so we completed a receiver operating curve analysis, which showed that actually our initial ratio was predictive of survival with a 75% sensitivity and specificity, which is the same as the prenatal marker. These are the images that I showed at the beginning of this talk. And so this first patient died and the second one survived. And I hope now what you can see is that how the mediastinum has moved in these patients is different between the two of them. And we've shown that this is impactful. We wanted to push this a little bit further, though. We wanted to know if how much it moves actually matters, not just where the mediastinum starts. And another way of thinking about this is to imagine two groups of patients, those who don't shift and those who do shift. And these two phenotypes we felt were different. And so if you can imagine a straight line down the vertebra of each patient separates patients into these two groups. And so our index equaled 1 when the mediastinum was central or along this axis. And so those who didn't shift had a mediastinum less than 1, which meant that the mediastinum was still compressing that good lung. And those who shifted meant that the mediastinum had moved off of that lung. And what we found was that the survival rate was 67% in those patients who didn't shift and 76% in those patients who shifted. This data has shown that the MSI is reproducible and easily completed. It's a postnatal measurement, but most importantly, it's modifiable over time, which is something that we felt was important for this patient population. We will continue to work with other studies to collect more data, and we're looking to identify how postnatal management techniques such as positioning, thoracostomy, and repair impact the MSI. Thank you, and I'd be happy to take any questions.
Thank you for your presentation, Paul Osley, Liverpool, England, Bangkok, Thailand. The MSI will shift according to thoracentesis. You know, we've traditionally been taught, to sometimes ignore the effusion, but it's been my practice to needle them, particularly when the physiology changes. Can you tell us, did the MSI correlate with the physiological data?
Yeah, so that's a great question. So we've been looking at if, for instance, if tidal volumes have correlated with the MSI or if duration of oxygen, and we haven't finished analyzing that data yet. And we also are hoping to link it to cardiac data in the future to look at the degree of pulmonary hypertension and if that's associated with the MSI moving.
Thank you. Very interesting findings. Did you try to correlate at all with any of the prenatal prognostics, like lung head ratio or total lung volumes?
Yeah.
To see if there's any correlation with that?
So we did. The initial MSI, like I showed, was correlated with the prenatal markers.
I may have missed this, but does this apply both to right side and left side diaphragmatic hernia?
Yeah, thank you for that question. These are both right and left-sided patients, and so it just depended, where the defect was, we measured to the contralateral side. So if they had a left-sided defect, we measured to the right side of the chest. If they had a right-sided defect, we measured to the left.
You looked at those. Was there a difference in the outcomes on the right side compared to the left? Because historically there would be in survival.
Yeah, we actually thought the same thing. We thought that obviously those patients who had a right-sided defect would be significantly worse, but there actually wasn't a big difference.
Great talk. If you looked at the patients that didn't shift at all, Keith Thatch, Johns Hopkins Health Children's, and why potentially they didn't shift or what was preventing, we've found obviously that shift being very important in our population, and really kind of push to make sure any which way we can get that heart to shift for the good lung to have best.
Sorry, I just wanted to make sure you asked why patients did not shift.
Correct.
Okay, great. Thank you. So we didn't specifically look at that patient population, but obviously we're very interested in it. This study focused on mostly how we can get patients to shift. But if we compared this to a historical cohort, I think we'd be better able to delineate. Something that we have started integrating into our practice is positioning patients to attempt to get the mediastinum to move over. And so I anticipate we'll be able to compare those to historical controls.
Thank you.
Thank you.
Our next presentation is YES-associated protein pathway signaling in a novel ex vivo fetal lung model of congenital diaphragmatic hernia, to be presented by Dr. Anne Seskleifer.
Good afternoon, and thank you for the opportunity to present. We have no disclosures. In CDH, the abdominal viscera compresses the lung parenchyma and results in pulmonary hypoplasia and lifelong respiratory morbidity. However, the underlying mechanism for the lung hypoplasia remains unclear. Beyond just mechanical compression, our lab seeks to identify the cellular pathways that are dysregulated in the developing CDH lung. Recent studies have implicated the YAP pathway in CDH lung hypoplasia. The YAP pathway is a mechanosensory pathway where activated nuclear YAP, or NYAP, promotes lung branching and differentiation, and inhibition results in relative hypoplasia. The localization of YAP matters. In cytoplasmic CYAP, this is the phosphorylated and inactive form, whereas nuclear NYAP is the dephosphorylated form that's able to activate transcription. Our lab hypothesized that the proximal distal abnormalities observed in the CDH lung are consistent with those of YAP dysregulation. Therefore, the aim of this study was to determine whether mechanical forces during the canalicular stage of fetal lung development affect YAP signaling using a novel ex vivo compression device. Time-pregnant CD1 mice were gavaged with either oil alone for our control group or with nitrophin and BPCA in order to induce a CDH fetal lung hypoplasia. At E15.5, the animals were sacrificed and whole lungs were harvested. This represents the canalicular stage of development where physiologic diaphragm closure occurs at E16. These lungs were then cultured for 48 hours ex vivo and either incubated in normal culture conditions or subjected to compression for 48 hours. The lungs that underwent compression were placed between 2% agarose discs and then subjected to a compression of 7.7 centimeters of water for the 48-hour time period. The tissue was then analyzed by quantitative PCR for gene expression of the downstream YAP target genes, including CYR61 and CTGF, as well as for immunohistochemistry looking specifically at the nuclear and cytoplasmic YAP proteins. Prior work from our lab has validated that the nitrophin BPCA model induces lung hypoplasia even in those mice that do not develop a hernia. In this graph, you can see in the blue are control mice, in the pink are nitrophin, and lungs that were subjected to compression are represented by this dashed pattern overlying the respective colors. The expression of both CYR61 and CTGF were downregulated in lungs exposed to compression compared to the control culture lungs. Likewise, the expression of CYR61 and CTGF was downregulated in the nitrophin-exposed mice. So this suggests that the YAP pathway and dysregulation of the YAP pathway is involved in both models of the CDH fetal lung. This image shows the immunofluorescence staining for nuclear activated YAP as well as cytoplasmic YAP in a control and in the compression model. In the top images, you can see the nuclear YAP staining pattern is more prominent in the control lungs compared to the compression lungs, which indicates that the YAP protein is able to activate transcription more readily in the control versus the compressed lungs. In the bottom row, you can see that the cytoplasmic inactivated YAP staining is stronger in the compression compared to the control, which would suggest to us that that YAP protein is getting stuck or trapped in the cytoplasm in its inactivated phosphorylated state. In conclusion, we found that YAP signaling is dysregulated in both the nitrophin and in the compression models of CDH, which was shown by an increase in the cytoplasmic YAP as well as a decrease in the nuclear YAP. And this was further supported by downregulation of the YAP genes CYR61 and CTGF. Taken together, these findings advance the concept of YAP activators and mechanosensory pathways as potential therapeutic targets in the treatment of fetuses who have severe CDH. Thank you.
Augusto Zani, Sick Kids, Toronto. Really elegant study, beautiful data, and beautifully presented. The question for you is if you know where this is all happening, if you know which type of cells are actually expressing the dysregulated YAP task signaling pathway, and also geographically. Of course, this is in vitro, so I appreciate that. But can you give us a little bit more information about the geography of where this is happening?
That's a great question. Thank you. That'll be a next step for our project, looking at where exactly the pathways are being dysregulated in the specific cells. Thank you.
Thank you.
I just wanted to say, in Mike Harrison's lab, or back when I was in San Francisco, they used to put balloons in the chest to create something similar in larger models. So it's not a unique thing. And then combining this with tracheal occlusion might be interesting to look at what happens, because then you're pressing from the outside and expanding from the inside. So
Absolutely.
Just a thought.
Thank you. That's a great point. In this study, we were specifically looking at external compression, but we also do have other papers that are coming out that look actually at the YAP expression and tracheal occlusion models.
Cool.
Thank you.
Thanks. Our next presentation is procedural burden experienced by infants who died in neonatal intensive care units. Dr. Christine Corkum from Children's Hospital, Colorado.
Thank you for the opportunity to present our work. I have no disclosures. Infants who die in the neonatal intensive care unit can experience high-intensity end-of-life care. From previous published studies looking at other critically ill neonates in patient populations, we have found that high-intensity end-of-life care can have limited therapeutic values, high costs, and can compromise quality of life. But less is known about the specifics of this high-intensity end-of-life care, specifically procedure type, timing, and frequency for our neonatal population. Therefore, our objective was to describe the operative and procedural interventions performed on infants who died in the NICU. We did this by performing a 2-year retrospective analysis from the Pediatric Health Information System database from January 2020 to December of 2021. We identified our cohort by utilizing FIS flags, including the NICU flag, as well as the mortality flag. We categorized the high-intensity end-of-life care into invasive procedures and major operations. For invasive procedures, we further categorized these into venous arterial access, laryngoscopy, bronchoscopy, device insertion, revision or replacement, arteriography, venography, and diagnostic and therapeutic procedures. Major operations were identified using the operative FIS flag and then further characterized according to the CPT codes. What we found was that just over 3,000 infants died in NICUs at FIS hospitals during the study period. Of those patients, 75.4% underwent one invasive procedure, and 44.5% underwent 3 or more invasive procedures during their terminal hospital admission. The most common procedures were venous access, and this specifically included PICC lines and central access, as well as arterial access. What we found was thoracostomy tube placement happened closest to the time of death, with a median day 4 days prior from procedure to death for this cohort. There were 934 infants who underwent a total of 2,043 major operations, so 30% of this cohort underwent a major operation. We found that those patients who underwent an operation, nearly 40% had an operative complication, and that 72.3% died within the 30-day postoperative period. I think most notably is that 35% of patients who had an operation died within 72 hours of surgery, and nearly 2/3 of these patients had an intra-abdominal procedure. We also looked at the ECMO utilization for this cohort and found that 8.7% of the patients were cannulated for ECMO during their terminal admission. We further stratified this looking at ECMO utilization across all FIS sites and found a wide range of utilization for patients who died in the NICU, from 0 to 30% of all admissions. So in conclusion, infants who die in the NICU experience a significant procedural and operative burden. we found variable usage of ECMO for infants who died in the NICU across FIS hospitals. And we want this study just to highlight the importance for the role of surgeon involvement in multidisciplinary discussions regarding the utility, potential benefit, goal concordance of major operations and invasive procedures for infants at the end of life. Of course, our study has limitations. This is only reflective of neonates and infants who died during their NICU admission. And then the inherent challenges in secondary data analysis from a large database, including lack of granularity in the admission diagnosis, no details on prenatal diagnoses, and it's difficult to extrapolate from the data whether or not these outcomes were anticipated. Our next steps are to do a comparative study looking at the procedural burden of neonates and infants who were discharged versus those who died in the hospital. Thank you, and I'm happy to take any questions.
Were you able to elucidate cause of death from this database, particularly those infants who died within that 72 hours of the procedure? Was the death because of their underlying disease or complication of the procedure that they had?
That's really hard to tell in this database, and I think will prompt future studies looking at more granular data so we can get at the risk factors and really kind of formulate a way to have these discussions for patients we may anticipate have poor outcomes.
Thank you. Our last presentation of the session will be a video presentation entitled Moving from What to Why, Devising a Purpose-Based Framework to Discuss Surgical Intervention in Seriously Ill Children, to be presented by Dr. Danielle Ellis.
Good afternoon. My name is Danielle Ellis, and on behalf of our group, I'll be presenting about the surgical trajectories of children with serious illness and our proposal for a framework to discuss surgical intervention using goal-grounded language that promotes goal concordance. The authors have no disclosures. So what we know about surgical intervention in children with serious illness is that it is extraordinarily common. In a subset of children with serious illness, those receiving palliative care, 81% of them underwent at least one intervention, and there were a median of 4 from the time of palliative care services being initiated. And so we know that for children with serious illness, in order to care for them well, we have to support and promote goal concordance. And goal concordance is predicated on high quality communication. Understanding the reason why an intervention is being recommended and what the intervention is meant to accomplish is essential to understanding how that intervention might align with the goals of care that a family and patient have. So we have some gaps in that we don't understand or know what kinds of interventions kids with serious illness undergo, why they undergo them, and in the absence of knowing those things, we certainly don't have a standardized or structured way of talking about surgical intervention with families and with other teams. So we performed a retrospective cohort study on a subset of patients who are enrolled in a multi-center prospective study of children receiving palliative care. We abstracted the surgical interventions they underwent from the time of their primary diagnoses through the time of data collection from their medical records. A surgical intervention included any procedure or operation performed under sedation or general anesthesia, so that did not include bedside procedures, though it did include non-surgical specialist interventions like those performed by GI or IR. We then use that information to develop a framework for discussing surgical intervention in terms of goals and purposes using a hybrid deductive inductive approach. In our study population of 197 patients, about half of whom were female and the majority of whom were white and non-Hispanic, there was quite a bit of medical complexity, so an average of 5.3 complex chronic conditions per patient. And almost 5 years between the time of primary diagnosis and the start of palliative care services. 89% of patients underwent at least one surgical intervention, and there was a median of 13 interventions over the course of patients' lifetimes by 21 different interventional teams. The top 5 most common interventions were intrathecal chemotherapy injection, central venous access, upper endoscopy, either for diagnostic purposes or interventional purposes, bronchoscopy, similarly for diagnostic or therapeutic purposes, and phenol Botox or steroid injection, the kind used for children with dystonia. So you might think that those top 5 don't strike anyone as being particularly surgical. Also included within the top 25 interventions were others that are much higher in terms of their risk profile and invasiveness. So enteral access, for example, was not in the top 5, but happened in over 50% of patients with cardiac, genetic, neurologic conditions, prematurity, respiratory conditions, and malignancy. So essentially a majority of the population of the children that we might encounter, over half of those had gotten enteral access. Complex cardiovascular repairs and cardiac catheterizations took place in about 80% of children with primary cardiovascular diagnoses. Tracheostomy took place in over half of children with genetic diagnoses and prematurity. And CSF diversion and oncologic resections took place in a majority of children with solid tumor and CNS malignancies. As we thought about the goals of care framework and the purposes framework, we started with the very well-established goals of care framework developed by subspecialty palliative care. The reason for that is that patients have been communicated with by palliative care teams for a very long time, and they've really mastered that communication. And so as they've thought about how to talk about goals of care in ways that really map onto what patients and families identify as important to them, we wanted to reflect that in our framework as well. So those goals include living as long as possible, living as well as possible, and then in the middle, this blended approach. We mirrored those exactly in terms of our goals of surgical intervention. And so we would say that a goal of surgical intervention could be to help a child live as long as possible, to help a child live as well as possible, or to live as well as possible for as long as possible. We conceptually separated the purposes from the goals and generated those categories of purposes to think about what we intend to accomplish with that intervention. And so the categories that we developed were first diagnostic, meaning that the intervention is purely for the purposes of identifying a problem. Curative repair, which means that the intervention is intended to fix a problem that may or may not be related to the patient's primary diagnosis. Temporizing or bridging, where the intervention is intended to bridge a patient from where they are currently to a more definitive therapy. Supportive, which might be thought of as traditionally palliative interventions, or an intervention that is meant to improve symptoms or relieve some sort of problem. And finally, assistive technology, where the purpose of the intervention is to place or maintain some sort of medical technology, whether that's a tracheostomy or a gastrostomy tube or something of the sort. The purposes of surgical intervention in our cohort really varied, which makes sense because the goals and hopes of families vary in a way that may surprise people. Even though this population of children with serious illness were all receiving palliative care, there's still quite a bit that was performed for the purposes of cure and repair, and then certainly another grouping that was diagnostic, and the remainder for supportive and assistive technology purposes. So a way that this might be incorporated for a patient and family would be to say that this intervention is being considered for your child because they have already been diagnosed with a particular condition or because we are concerned about that condition. We could then move on to say that this intervention is for example, curative one, meant to repair what is going on. And then we could include the goal there to say that our main goal is for this intervention to help your child, for example, live longer. So the reason why this matters is because between the invasiveness and the really high incidence of surgical intervention in children with serious illness, it really features prominently in their stories. And surgery in many ways shapes those stories. The second thing that's important for us to take away from this is that how we talk about those interventions can help families actually write those stories for their children in ways that make sense for them. So when we use goal-grounded language, we can promote goal-concordant surgical intervention, and we can improve alignment between families and teams. Thanks so much for listening, and we'll take any questions.
All right, I don't believe we can actually do questions. It's a video, so I think that was our last talk. It is lunch, so if you purchase tickets for the Benji Brooks luncheon, it's in the Grand Sonoran Ballroom. Everybody else, your lunch is in the foyer, as usual. Thanks to my co-moderator and to all the great presenters today.